Support for this episode comes from Omnipod. I'm amazed how hard these automated insulin delivery systems work. Omnipod 5 automatically increases, decreases, or pauses insulin delivery every 5 minutes. This technology is called Smart Adjust, and it's in the pod. This means if you're out on the football field and the controller is in your bag, the pod and Dexcom G6 continue to talk and make adjustments. That would have been awesome for us in middle school when Benny played football, or when he was backstage at the school play. All that, and you get the freedom of no tubes. Fill out the quick online form, see if you're eligible for a free trial. Go to diabetes-connections.com and click on the Omnipod logo. For full safety risk information and free trial terms and conditions, visit omnipod.com/diabetesconnections.
This is Diabetes Connections with Stacey Sims.
This week, we're hearing more and more about prevention of type 1 diabetes, and there's some big news on this front. Just last week, Diamyd Medical got fast-track designation for its medication to stave off type 1 for people who carry a particular gene that about 40% of people with type 1 have. This isn't approval. There's still a lot of clinical trials, and Diamyd is recruiting. We'll find out who's eligible, where you have to go, what you have to do, and the reasons why there's an awful lot of hope around this. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Welcome to another week of Diabetes Connections. I'm always so glad to have you here. You know we aim to educate and inspire about diabetes with a focus on people who use insulin. How's your summer going? Yeah, it's hot. It's hot everywhere, right? I mean, I was just in Orlando, almost 2 weeks ago as you're listening now for the Friends for Life conference. And, it was really hot there. But I have to say, it's better here than it used to be. And I mean inside, because I completely forgot. When I started this podcast back in 2015, I was holed up in my attic and I could only record early in the morning or at night. We moved in 2020. And so I really do appreciate my air-conditioned office on days like this. I can't turn my fan on because it's too noisy. But oh my gosh, it's so much better. I was just remembering melting in that attic. Okay, quick reminder, don't forget Mom's Night Out registration is open for our next 2 events. We will be in Denver in September, Philadelphia in October. All the information over at diabetes-connections.com. The early bird special prices will not last much longer, so if you've been thinking about it, please go ahead and get your tickets. I'm announcing the 2025 cities pretty soon, probably September. We let the cat out of the bag for one of those cities at Friends for Life, and it's actually on the website, so you can go check that out. My friends in the Southeast are going to be happy, but we are not coming back to Charlotte. All right, my guest this week is Elna Narula. She is the U.S. Site Relations and Patient Recruitment Lead at Diamyd Medical. Elna's daughter was diagnosed with type 1 more than 30 years ago, and Elna was already working in healthcare, and she became a diabetes educator, which led her eventually to Diamyd. And as I just mentioned, Diamyd Medical has received the fast-track designation for their medication, also called Diamyd, from the U.S. FDA. This is a medication to prevent type 1 diabetes. So that approval, or designation, I should say, it's not an approval, that designation happened just last week after I had already talked to Elna. So that isn't really part of the interview, but she has a lot of information here. Please make sure to go to diabetes-connections.com. Click on the episode homepage for this episode to get all of the links and find out if you are eligible for the study. Our conversation right after this. Managing diabetes doesn't need to get in the way of your passion, your social life, or your budget. EdgePark can help you simplify your diabetes journey so you can focus on other important things. EdgePark offers a wide array of continuous glucose monitors, such as the Dexcom G7, Freestyle Libre 3, and more. Plus, EdgePark accepts most insurance plans and handles the paperwork. Go to diabetes-connections.com and click on the EdgePark logo to learn more. Elna, welcome to Diabetes Connections. I'm excited for this conversation. We've talked a bunch about this, but now let's get the word out. How are you doing today?
I'm doing great. How about you?
I'm really well. Thank you so much for asking. Let's start with the basics. What is Diamyd all about?
Sure. Diamyd is the name. It's 2 things. It's the name of our Swedish biopharm company. We're pretty small, 35 people, doing the work of quite a few more. And based in Stockholm, Sweden, we have been working on GAD, and our mission is to really cure autoimmune diabetes. Really, for over 20 years, we've been working with GAD. So it's the name Diamyd comes from the founder, Anders Essen Mahler, who had a daughter with type 1, or has still a daughter with type 1, but many years ago, we're talking over 25, 30 years ago, he wanted to find a cure for diabetes to some of his daughters. So it's called Diamyd because dia stands for diabetes. Her name, Swedish name is Mai, M-Y, and then D is the last letter of GAD. So it's Diamyd. So Diamyd Medical, we sometimes say that to differentiate it from the name of the Diamyd GAD drug. So Diamyd Medical is the name of the company. Diamyd, with a registered trademark, is our investigational product, GAD.
Okay. Before we go any further,
yeah,
what is GAD?
GAD is one of the most important biomarkers that you have type 1. So when you get type 1, you are checked and screened for the autoantibodies, right? Most people have GAD, not everyone, but it's one of the ones along with insulin autoantibodies and zinc transporter and all the others that are out there and that you read about with TrialNet and screening. And GAD, what we do, what our GAD with alum RH drug does, that we've been studying for over 20 years and very safe. It's been in over 1,500 people, has a really robust safety profile. So what happens is our GAD goes in and tells the GAD that is attacking the insulin-producing beta cells, stop it. This is not a foreign thing. You're not supposed to be doing this. So it modulates the effect of GAD on the beta cells to stop the autoimmune attack. So what we're testing, and have tested before in previous trials, is to see if this indeed does slow down or prevent the autoimmune attack on the beta cells, thereby preserving your precious insulin production, which always helps in the long run. The more insulin you have, obviously, and C-peptide. We do this by the endpoint checking the C-peptide. So it's neat because we call it immunomodulator rather than immunosuppressant, because it doesn't suppress the whole immune system. It just modulates that effect of GAD. So somebody does have to be GAD positive to screen for it. And they're screened for that in the trial.
Before we move on to that trial, how early do you have to catch this? And how do you catch this? Because it's hearing about these prevention trials and these medications seems so new. I know you've been doing it a long time.
Yeah. And there are more trials now going on at diagnosis and before diagnosis. So if you remember, there's stage 1. We've all figured out after many years how complicated type 1 actually is. And so there's stage 1, stage 2, stage 3. Stage 1 is the one with just 2 autoantibodies. And then you have stage 2 with autoantibodies and dysglycemia, abnormal blood sugars. And then stage 3 is when you're actually diagnosed and you have the symptoms along with that. So there are other trials going on, other JDRF funded. We are also a JDRF partnered funded trial. And there is more, there are more new onset trials, which is great. But this is the only one now, because I think the Gladiator study, Dompe, is no longer in stage 3. They'd go back there in stage 2 again, I think. That's correct. Anyway, we're the only one in stage 3, in phase 3. And for your listeners, all clinical trials have phase 1, phase 2, phase 3. Phase 1, you're starting safety. Phase 2, you're looking at safety and having a bigger population, maybe in the hundreds. Phase 3 is usually really testing it in a much larger population for efficacy and, making sure the thing really works. Interesting thing about GAD in this trial is that there were other new onset trials about, 10 to 12 years ago. Diamyd was doing DiaPrevent study where we were giving subcutaneous injections right under the skin. And at the same time, Macrogenics was doing what was then teplizumab was with them, right? Also for newly diagnosed. And Tolerix was doing a study. So there are 3 companies. And unfortunately, none of them quite met their endpoint, but we learned a lot from them. So Tolerix didn't come back again. Macrogenics ended up, licensing teplizumab to Prevention Bio, and now Sanofi has it and stuff. So they didn't give up on it. They came back, and we've never given up on GAD. We came back again, figured out a better way to give it directly into the lymph nodes. So they get 3 injections right in the lymph node. And we found out that it works from all the meta-analysis, the big analysis of all the previous studies in that big phase 2 trial that was both in Europe and in the US. And because it didn't quite meet the endpoint in Europe, we had to shut down our US trial. We had just finished enrolling. But we learned a lot from looking at the data, that it worked in a particular group of patients. And particularly found this with the phase 2 trial we finished in Europe just 2 years ago or so. And that it works in about at least 40, maybe 50, but 40% of type 1s who have this genetic component called HLA, DR3, DQ2. It's really the first precision medicine ever in type 1 diabetes.
Lots of questions. And you mentioned others. It went by very quickly, but we have talked about teplizumab several times on the podcast. I know people now, which is incredible to me.
Yeah.
I know several people whose kids have had this administered. They feel, they are preventing it for now, or at least staving it off. I thought, I'm really not sure what language to use yet, right? Because to me, prevention sounds permanent. So I'm trying to figure out, just as a layperson and a mom of a kid with type 1, how to talk about this stuff. But I wanted to ask you, you mentioned teplizumab, which is approved by the FDA. Mm-hmm. Does that help you all in your move forward?
Yes. The reason being, it's when anybody opens up awareness about the fact that, hey, maybe we can prevent type 1. Because, there's prevention, there's cure. Mm-hmm. We ultimately do want to cure type 1. And we are doing other things as well. Diamyd's very dynamic in other projects and investigator-initiated studies. That means there are others outside of Diamyd connected to us using our GAD and GABA as well, the things that we have licensed to also move towards a cure. We've also done a booster trial to see if we can prolong once it's prevented. So what I wanted to say is that we do a lot also in the screening in Scandinavia, and a lot of European countries are way ahead of the US with already screening for type 1. That's a very important thing to us, and we're working on a big project, the ASSET project, with others in Europe on screening kids. They do that in southern Sweden. They screen kids already. They're really ahead of us here and in Denmark and Slovenia and other places. When you talk about prevention, the best way to prevent is to screen early. Teplizumab is in stage 2. That's why it's also hard to find people in stage 2. They have to be screening. And that's why there's such a focus too. There is more awareness about the need to screen. TrialNet's been out there for a long time. So we're working in that space as well, but we're doing GAD in stage 3 once they've been diagnosed. But our hope is, like the hope of a lot of people working on this, because there are many screening programs done. There's the Frida, there's the Barbara Davis is doing it. There's another one with, JDRF is doing it. Sanofi's doing it. I mean, there's many opportunities to be screened. So real prevention, the best thing is if somebody has type 1, then it's good to have family members screened. And hopefully it'll be just like, we do PKU. I used to be an OB nurse in babies. They all get tested when they're born. Hopefully someday in this country too, they'll be tested for type 1, celiac, other autoimmune things early on. Because if you know what you're dealing with ahead of time, and there are these different things out here that maybe can prevent or save beta cells and do the same kind of thing for other diseases, it's really important.
That's great. Talk to me a little bit about the trials. Are you looking for people now?
Oh, yeah. So we're in 8 countries in Europe. They started before us in the US. We are in about 12, but it's going to be 14, hopefully, sites here in the US. And about more of those, probably about 3/4 of them are open right now. And we're looking for those who are ages 12 up to 29, diagnosed within the last 6 months. Some other studies are up to 3 months. Some are longer. Some are, different ages. You really have to look, but there are others out there. What some of our sites like, and we like, is that, people can come and screen for this one to see if they have the HLA. If they don't, then there are other studies still out there, but it depends on obviously their age and when they were diagnosed. And then there's always other criteria, what they call inclusion criteria, whether somebody can be included or not. The neat thing for our trial too is because we have fewer sites. I mean, I've been on trials before. You like to ideally have 20 or 40 when you are trying for a phase 3 clinical trial to recruit a lot of people. You're usually looking for about 330. So you usually want to have a lot more sites. Mm-hmm. We have a lot of sites if you count them in Europe, but for the US, it would be nice to have more. So we will pay for travel. So if somebody's in Anchorage, Alaska, which we've had before, and they want to come and be on this trial, we will take care of what it is for traveling. And the most important thing, and why I love talking to you and anybody else about this trial, is because we just need to spread awareness about it. People, the number one reason there aren't more people in clinical trials in the US, and there are a lot of good clinical trials going on. I don't live far from NIH, and at least NIH is putting the word out these days by sending things to all the households. They didn't used to do much at all, but they do a lot of neat trials. But the reason people aren't in trials is because they don't know about it. So this one, what's really important to me is we have to screen twice as many to find those with the HLA component. So we have to get the word out. So
Wow.
Anybody listening to this anywhere, if you know others with type 1, connections with, please, they're newly diagnosed. At least they need to know about this trial, go to our website and see where the sites are and be in touch, and they can ask any questions. There's lots of info out.
So, you may have already said this, Elna, so I apologize if this is redundant. But so what does someone need? You need to be newly diagnosed. Can you tell us about the criteria? Right back to our conversation. But first, Diabetes Connections is sponsored by Gvoke HypoPen. Gvoke HypoPen is a ready-to-use rescue pen for treating very low blood sugar in people with diabetes ages 2 and above. If you take insulin or sulfonylureas, you're at risk for your blood sugar going too low. Low blood sugar emergencies can happen unexpectedly, and they demand quick action. You need a safety net when it matters most. Be ready to treat very low blood sugar with Gvoke HypoPen. Find out more. Go to gvokeglucagon.com/Stacy. That's gvokeglucagon.com/STACEY. Gvoke shouldn't be used if you have a tumor in the gland on top of your kidneys called pheochromocytoma, or if you have a tumor in your pancreas called insulinoma. Visit gvokeglucagon.com/risk for safety information.
Newly diagnosed within 6 months, right? So 6 months of the date you're diagnosed, you have to be screened at a site. So our sites are 3 in California. I mean, I can just say, let's see, we've got San Diego, we've got LA, we've area Newport Beach, we've got San Francisco, we've got hopefully it'll reopen the one we have up in Bend, Oregon. We've got Idaho Falls, we've got San Antonio and Amarillo, Texas. We have St. Louis. We have Miami. We have New York, which will open. We have Boston, Joslin Center, and
Denver
in Colorado. Yeah, I'm sorry. I really didn't need to take all your time to do all that.
No, that's okay. That's okay.
But they're spread around the country, and people can get to them. And we have a lot of people who found it, been very excited and wanted to travel and would do anything they could.
Yeah.
Get there. I mean, somebody was turning 29 on Saturday. She contacted us on Thursday. She got to a site on Friday. Unfortunately, she didn't have HLA, but whatever. Then there have been others, whose birthday was coming up. Not birthday, sorry. Their 6-month time. That was her birthday, 29. So as long as they're within that time. Unfortunately, we meet a lot of people at events who, it's been 10 months for somebody,
Sure.
or they're 34, or their child is 8 years old. We are doing another study. It's just starting, called Precise in southern Sweden, with kids 8 to 18 to test this as well. Because what's different this time around from what we did years ago? Like I said, you learn from what you've done. A lot of trials don't ever get to come back, Stacy.
Right.
We're fortunate that we did, because a lot need to go back because maybe there was some efficacy there, but they don't, they're millions and millions of dollars. It's like a huge campaign to do a clinical trial. So we came back and we're giving it directly into the immune system, which is different. They do it in some allergy clinics, progressive allergy clinics. That's where it's been studied, and in some oncology places. I think we're going to see more of it in the future.
And for the one you're recruiting for, you mentioned the different cities in the U.S. What is the age for that?
Same, 12 to 29. So we have both pediatric and pediatric adolescent adult endocrinologists in clinics.
12 to 29.
Some of the adult endocrinology clinics are connected, with the hospital or their academic center, Stanford, with their other children and adults. So a lot of them will take them up to that age as well. But all of the sites and the whole inclusion for this study is from age 12 up to 29. But we're doing, like I said, the thing that's different about it, maybe we're going to ask this, but I'm going to jump to it, is that we're giving it directly in the immune system. It goes in an inguinal. So that's, one of your superficial nodes in your groin, inguinal. And it sounds scary and weird, but if you think about it, a lot of people have thyroid biopsies. And so endocrinologists, some have been trained in going in and going into thyroid and the node there and taking something out. So some of them are doing this, but they're all ultrasound guided by a trained radiologist or an endo who can do it to see the lymph node. And then it's just given in there, comes out. Nobody has ever left the trial in this trial or phase 2 in Europe. We've done this so far, and they describe it as being no more painful than having blood drawn, getting an IV started, and they can have Emla cream if they want. So it's a really neat way to give it. And the fact that we're doing it just for the population who are who've been shown to respond. So hopefully it should work. It's just the job of finding the patients for it. And this is a hard time for a lot of trials because it's just harder to get people that maybe after COVID, and they hear clinical trials, and then there are quite a few more going on for newly diagnosed and others.
Yeah. People in this trial, do you have, like you said, you've been looking at this for a long time, but would it be reasonable for people in this trial to feel like they either got a placebo or they got the actual drug and it works? Like, are people seeing, can some people expect to see results to see this prevention?
That's a really interesting question because you can't see kind of what your C-peptide is and stuff. However, maybe you can see with what's happening with your blood sugars and how much time in range and things like that. When you're so new, things fluctuate anyhow because, the honeymoon period. And it's like after you're diagnosed and you start getting insulin, what my understanding is your beta cells have a little bit of a rest, right? After what they've just been through. And so people sometimes don't need insulin in the beginning, or they're doing really well and they think, I don't really have this, or I'm okay, or whatever. No, you need insulin, whatever. So because it's that kind of a period, I think it's a little hard for people to tell right off, but that's what's so neat about this booster study. So Johnny Ludvigsen, who's been behind GAD for years and years and years. He's in his 80s. He's a wonderful guy. Wears his heart on his sleeve. Johnny's just terrific. And he's the one who figured out, wait, let's give it intralymphatically. Wait, let's check their vitamin D levels. Let's give extra vitamin D. And let's make sure they're fortified when they get it. It's great. Just smart things. That's the way I look at it because I've been doing research stuff for a long time. And I really like the way we're doing this trial. So what he did is he did a booster trial just with a few patients. But it was kind of interesting that taking people who might have had GAD subcutaneously, which means under the skin, that's the way we gave it before. Most shots are under the skin or intramuscular, but you don't really know how much gets in and all these other things that can affect. When you go directly to the immune system, it gets where you're going. So he did a study and had people who'd gotten it subcutaneously years ago and to see, and then giving an extra booster and looking at how much C-peptide they had. There could be something promising there with being able to give boosters. People have asked about that before. So if you can help prevent or stop it or something, what if it starts coming back? Can you give something later on? We're able to show maybe so. So that's another promising, interesting aspect of this. So when you say that, I want to say one other thing too, if you see results. I once worked on a rheumatoid arthritis trial. It was very interesting. So a lot of things they do there in autoimmunity and the way they figured out. You try one drug, methotrexate doesn't work. So you try another one and you add on and do things. And we're beginning to do a little bit more of that in type 1. Look at, are there any combinations? And how we've experimented with type 1s using GLP-1s and different things over the years. So it's kind of interesting. But there, it was really interesting because on the RA trial, they would have people come in. They would say at the sites, we know she didn't get placebo. She got the real thing because she felt so much better. And she said she hadn't felt this way for years. So I don't know that we see as dramatic with that right away, but certainly that's what we're looking for over the course of the time after they have their injections when they're followed up. They keep an e-diary of things. We're watching what their sugars are. They're wearing continuous glucose monitors, and they're having.
I have a friend whose child was in the early teplizumab trials.
Nice.
And it was wonderful that they were able to do it. They were here in North Carolina, but they went down to Florida. He was, very early on in the diagnosis. He's my son's age. They're friends. It was double blind, so they had no idea whether he got the teplizumab or placebo.
Yep.
But they feel confident. Who knows that he did because he's, as I said, the kid is, I think he's he's 19 now. So he was about 16 at this time, 15, 16. And compared to what my son was using in insulin, this kid was using like droplets of insulin for 2 to 3 years. So it was really amazing. And now I think things are a little bit more quote unquote normal. It's a few years later and he certainly wasn't taking the follow-ups if there are such a thing. But it was really interesting to see. So I was curious about that. I mean, I don't know if they've unblinded that study, if they ever will know, but they really think that for 2 to 3
No,
years to use 4 units of insulin.
They have.
Oh, they have. I should ask them. Because for 2 to 3 years to use 4 units of insulin a day as a 15 and 16-year-old.
No, I saw something similar. So when my daughter was first diagnosed, I have a daughter who was diagnosed at age 9. Swati is now 32, about to get married. And all I did, I stopped I was working as a nurse for 3 months. I looked around the whole world, not just the country, to find anything to save beta cells, because I talked to a researcher at NIH who was very kind to me to help me figure out what can I do to save beta cells. I'd done research. And she got into a trial that we had moved to NIH, and she was number 5 of 500. And study coordinator of ours, already, who I've known for a long time out on the West Coast, her daughter was also in the trial. And I think she got the real thing, and my daughter didn't, right? I still have a little thing of the placebo up there. It was liquid, just something they took every day for a year. And they did see. I talked to both the person who ran it at NIH and the main principal investigator from Houston, and they did see a difference with some kids. And certainly she did with her daughter at that time, whereas I didn't really with my daughter as much. And then when it was unblinded and we knew who got it and who didn't, you could see something there. But this is an example of something that never got to come back and won't see the light of day, or at least it hasn't yet, because they all believe, these researchers, there was something to this that could definitely help, but they didn't have the money, the company, the backing. This was just one researcher who found this, and to go back and have it become a study again. Yeah. So that's what happens in research. It's sad. Most trials fail. The ones that are lucky enough to make it have to go through a lot to get there.
I was going to ask you about your daughter. So tell me about your experience with type 1, your family's story. She's an adult now, but tell me about it.
Well, what I can say is that I'm so glad we got into research things early. I was always hoping she'd become an endocrinologist. So I remember when in middle school or sometime when they shadow somebody to see, because in the US, they're earlier rather than later. They're like trying to get them ready for, what do you want to be when you grow up? It's like, I don't know yet. Don't push them. Let them, then they're getting into high school, the same thing. And slow it down. That's anyway the way I felt. But I was secretly kind of hoping. And she went and she shadowed a person. She'd been in a lot of her trials. And so she was in a lot of different trials. And I think that always helps. I think there are tremendous benefits being in clinical trials. She was in the first ones with bionic pancreas, the Damiano up in Boston. And first time I went to visit her one time, she was going to college up to me. She had like 2 IVs in both arms, and we'd all have to help her get to the bathroom, come back. She's in it like 2 years later when they were walking around with backpacks, and a nurse would go and they'd keep refilling the glucagon and the insulin stuff. Didn't have to do anything. Now, that's gone on to become beta bionics, and it's just insulin only right now, but they're going towards that. But I think being involved in research has been really neat, and it made her become the athlete she's become. And, she had really good friends at camp. And I learned a lot as a diabetes educator at camp working in the infirmary. So to me, I think being involved in this community and everything going on has only been, really beneficial. And I ran a support group a JDRF support group for families in our DC area for years. And it's just, I would always tell these moms, I'm so sorry this has happened and, you've become a part of this exclusive club that you never asked to be a part of. But I promise you, through this, you'll meet the nicest people you could ever meet, because such an amazing community.
How old was your daughter when she was diagnosed?
9, which I think is a good age. I think toddlers, it's tough. Teenagers, it's tough. Adults, it's tough. It's tough for anybody.
Sure.
But at least at that age, she just started 4th grade and turned 9. And we were coming back from vacation and driving. She was like, had to keep going to the bathroom, was tired. And I thought, she probably got a urinary UTI, right? Even though I was a nurse taking care of high-risk pregnant women, and one of the high-risk pregnancy conditions was diabetes. And then when she came home from school, the first or second day of school, and said, I had a headache. I couldn't stay awake on the bus. Oh, wait a minute, I've got to go to the bathroom. Boom, light bulb. And so I had a glucometer, meter right in my little nursing bags that we did home care nursing for these women on high-risk pregnancies and diabetes and stuff. And she calls out to me, I'm making dinner. Mom, is 464 a problem? And my heart sank.
Oh.
But I had no idea of, I didn't know about that. I was already working with others with type 1, type 2, but I didn't know about the Dawn phenomenon, all this stuff. We went down and had, you have the teaching and stuff. And I remember thinking to myself, oh my gosh, if I'm a healthcare professional, I'm a nurse, I work with women, I work with this stuff, and I didn't get type 1. I thought I used to take care of people. I really didn't understand what it was all about. And then I used to think, if I had to learn this, how is it for lay people? But anyway, so my daughter took it, and I think she's always been somebody who kind of took lemons and made lemonade. So it made her become what she's become. She's a journalist. She writes about a lot of things, does stuff. But she started off by writing for things online and in high school and things about diabetes.
It's quite something. It sure is.
Yes, it is. And but that's why I think there's such a special, there are two things. I think there's special camaraderie within the type 1 community and moms, you and I are a mom, and others, because we understand what it's like. And for other people who don't out there, and they often say this about chronic diseases, they're kind of, if they're invisible, you look like you're fine. So people don't get it unless you live with someone with type 1, right? Or something. It's hard for people to get it. That's what I'm saying too, even as a healthcare professional. You have to really understand or be with it to get it, and that's why there's that camaraderie. The other thing is what I do remember about her, and I want to say, if you've got other parents on this podcast who have kids that are going to go off to college and stuff. So my daughter, I remember the first time she went off to running camp, and I always made sure, there were two things. And also as a diabetes educator with patients, do you have, some kind of, medical alert thing? I don't care if you tattoo your chest, just because I've seen things, heard stories, known people, adults and others who didn't have something there and didn't have their glucagon, and it wasn't good. So always making sure somebody has some kind of medical alert thing and glucagon, some kind of glucagon. So thank goodness we have much better options now. So what I wanted to say is, for parents with kids going off to running camps, college, doing things, now at least we have CGMs that a parent can see on the phone. We didn't have that a long time ago. I used to get up every night until we had CGMs, right? I've got all kinds of stories I could tell you about that. But going off to college, that symbiotic tie you have as a mom with a child or whatever, and I guess could be a dad too. Once they're not there, I would try to always tell kids, and even at camp, when parents are leaving kids at camp, they'd be fine. The parents, I remember the first time my daughter went off it was like I worried all night, and I kept calling the other mom who was my friend, but her daughter had gone for the first time. And of course they were fine. Did they brush their teeth enough in there? Who cared? And did they even brought down extra sleeping bags because it was colder and just left them so and see? They never even used those. It's the parents. So the same thing with college. So I would often tell kids in doing workshops or things about going off to college, please, just for your parents, I can tell you, I had to tell my daughter, I understand, you're maybe fine, but maybe I just need to know, because with CGMs or whatever, I said, I just need to know that you've woken up in the morning and did when she first went to college, that your blood sugar is okay or something, or, you're going to be away and going somewhere. So I'm not worrying you're lying somewhere with a low, or, there's that symbiotic kind of thing that it takes time for parents to kind of let go, and for kids to understand parents need. They took care of you all this time, and then you're just off running and doing great. It's great if you were raised well and you have enough understanding that you can take care of yourself. But it's like, just keep in touch with that parent.
Call your mom sometimes, kids.
Yeah.
Let's go.
Yeah.
I love it.
Right. So that's just the other thing that I'm talking about.
Yeah. Well, I'm a mom of a kid who just came home from college. Benny was away for the first year. I think I think we did it a little differently than a lot of parents. We're going to do a whole podcast episode when I interview Benny. Spoiler alert, he did fine. I have different standards, what I would like to see. Our endocrinologist tells me all the time, it's not your job anymore. It's his, and he's fine and he's safe. And don't worry about it. Ha 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 ha. He doesn't really mean don't worry. He means do not worry that he's not doing enough to take care of himself. Because I think we all worry. But I'm really interested to unpack it with Benny, because it's really been a great year, but it was not a perfect year in any way, shape, or form.
No,
so
I get it.
There. Yeah.
I get it.
Before we wrap it up, did I miss anything about the study?
Please, we just have to get the word out there that there is this option. I try to tell I'm a diabetes educator, and I try to tell other diabetes educators, let people know about all the trials out there. Type 1, there's all kinds of technology trials there, mental health trials, because the more information we have, the more it helps, right? And people can't do them unless they know about them. So I think having people aware of them, spreading the word about them is good. You have, when kids are newly diagnosed or even adults, you have some who go to the web right away. They look for all the research. They're doing stuff. I know we get phone calls from them, clinical trials at Diamyd.com and stuff. And they clearly know the value of research and want to be in it and things and have a lot of questions. And that's great. But not everybody's like that. And some don't have all the support and things. So we want to get to the underserved population too.
Well, we will link everything up. We will let everybody know. We will definitely get the word out. Elna, thank you so much for joining me. Best of luck and keep us posted.
Thank you. Appreciate it. I enjoyed this.
You're listening to Diabetes Connections with Stacey Sims.
That was a lot of information. There's more to find out to see if you are eligible. So please head on over to diabetes-connections.com or check in the show notes wherever you are listening. I do put links in for lots of info for these episodes. If you can't find it, you can always just email me, Stacey at diabetes-connections.com. Quick programming note. We will not have an episode the first week of August. So I'll be here next week, but I will not have any episodes the week of August 5th. We're taking some vacation. My family and I are on a quest, just the four of us, to go to all 50 states. We started this when the kids were younger. I wish we started it when they were teeny tiny. It would have been a lot easier. And our rules are simple. All four of us have to be together, feet on the floor, so airports don't count. That's how we're doing it. If it's just a connecting city, we don't count it. And we need a picture of everybody together. And I wish I started them when they were little because they are now such independent people. My daughter has graduated from college already and Benny has been working all summer. So it's so hard to get everybody together. This is our 1 week together for the whole summer, which I know a lot of you are used to if you have older kids or bananas schedules, but I'm not used to it yet. So I'm excited, but I really wanted to just soak in all the family time I can. So we're not doing any podcasts that week. In the meantime, thanks to my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. I'm Stacey Sims. I'll see you back here soon. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Sims Media. All rights reserved, all wrongs avenged.
Like most of you, we don't love worrying about insurance. I'm thrilled to tell you that Dexcom CGM is covered as a medical benefit for 98% of commercial insurance plan holders who have type 1 diabetes. And more plans cover CGM for people with type 2 who use insulin. We even have it as a pharmacy benefit, so I can process it at the local pharmacy. They put it on auto refill for me, which makes it really easy. It's one less thing to think about. It's worth checking to see if that's available to you. And Dexcom will even help you do a benefits check to see what your insurance covers. It's easy. It's right on the website. Dexcom is the #1 covered CGM brand. Learn more, go to diabetes-connections.com and click on the Dexcom logo.